Good morning. Welcome to the Young Physicians Forum. So today, as usual, we have two speakers. So on behalf of the Ceylon College of Physicians, I would like to welcome all of you who have gathered here. And let me introduce the first speaker, Dr. A. Nimalan, Acting Consultant Gastroenterologist, National Hospital, Kandy. He will speak to us on exploring non-invasive approaches for liver fibrosis assessment. Over to Dr. Nimalan.
So in this agenda, first of all, I'll take why liver fibrosis is important in our clinical practice. Then the assessment of liver fibrosis, in which I will talk about traditional invasive assessment and the non-invasive assessment. Then the importance of non-invasive assessment in the assessment for fibrosis and how to utilize the non-invasive tests in our clinical practice. And finally, I'll talk about assessment of clinically significant portal hypertension and paradigm change in the management of clinically significant portal hypertension. So as you see, I'll take you from the normal liver to decompensated cirrhosis. So first of all, most of the chronic liver disease, the pathology start with steatosis. So steatosis means it may be due to non-alcoholic, metabolic associated risk factors, alcohol, Wilson disease, or other drugs can cause steatosis. So persistent steatosis can lead to lobular inflammation and then leads to NASH, that is non-alcoholic steatohepatitis. So with the progression, it will goes to early fibrosis, from which point it goes to advanced fibrosis and then to compensated cirrhosis. From early fibrosis, it progress like there are 4 grades of fibrosis, F1 to F4. There are rapid progressors who progress rapidly, whereas there are other people progress slowly. Those are called slow progressors. And from the compensated cirrhosis, if there is persistent insult or the disease progression leads to decompensated cirrhosis. As you see, when there is a reversal of insult, that means treatment of the hepatitis or treatment of autoimmune hepatitis or reversal of fat accumulation with weight reduction may reverse the whole process from early fibrosis to NASH or to even normal steatosis or normal liver. And there is another new entity called recompensation. Recompensation means once the patient is decompensated with the reversal of pathology. For example, if the patient is alcoholic cirrhosis presented with a decompensation, with the abstinence of alcohol, patient will end up in recompensated state. So that means the patient's prognosis is good unless he maintains the maintaining the abstinence. So in the background, liver has a considerable regenerative capacity in the acute liver failure. So most of the acute liver failure, for example, like hepatitis A or something like that, because of the regenerative capacity, without any intervention, they may recover. But the chronic insult, so for example, chronic insult is, as I have discussed above, the insults are like accumulation of fat, viral infection like hepatitis B, C, and metabolic associated liver disease and hemochromatosis, Wilson disease. So the damage from this chronic insult end up in emergence of hepatic fibrosis and end up in chronic liver disease. Right? So fibrosis occurs as a gradient of severity which increases in the presence of continuing insult, and fibrosis may also reverse with the removal of injurious agent or infection. That is also I have discussed. So this is the prevalence of NAFLD, or the new terminology is MASLD, metabolic dysfunction associated steatotic liver disease. So the prevalence of NAFLD is worldwide prevalence is around 25%, and the prevalence among diabetes is around 55.5%. In the Sri Lanka, there was a study conducted in Ragama in 2007 showed prevalence of NAFLD is around 32.6% with an annual incidence of 6.2%. So then we move into the assessment of liver fibrosis. So first of all, we should know why the why the assessment of liver fibrosis is necessary. So there are various reasons are there that the liver fibrosis should be carried out. So one is the monitoring the disease progression. So disease monitoring the disease progression is important to assess the state of the liver. And other thing is the treatment planning. So depending on the degree of fibrosis, the treatment and the intervention differ from lifestyle changes to medications, and sometimes we need advanced therapies depending on the degree of the fibrosis. Other thing is the preventing complications. So as you all know, the advanced liver fibrosis and cirrhosis are associated with high degree of or severe complications. So if we identify the complications pretty early, we can do potential interventions to prevent those complications. And other thing is the prognostic information. So the prognosis is depends on the degree of fibrosis. So F1, F2, F3, F4. So when you consider this degree, so F4 fibrosis and advanced chronic liver disease, cirrhosis have worse prognosis. So if we have a clear idea on which stage the patient is in, we can easily discuss the prognosis with the patient. Another thing is the trial enrollment protocols and endpoint of the clinical trials includes these includes this assessment of fibrosis, because some trials inclusion criteria may involve the early fibrosis, and some trials the endpoints of the trial might be the initial point of the fibrosis. So these are the methods we can use for the assessment of the fibrosis. First, we can broadly categorize into invasive methods and the non-invasive methods. So invasive methods, there are liver biopsy, that is a gold standard thing to assess fibrosis. And other one is the non-invasive method. So non-invasive methods, there are conventional imaging like ultrasound scans and shear wave elastography such as fibroscans. And there are direct and indirect serological panels, so which we talk in a little while. And other thing is combination of the non-invasive test. Other thing is the emerging technologies, which includes genetic or genomic panels and assessment with the gut microbiomes. So liver biopsy traditionally considered as a gold standard for assessment of the advanced fibrosis, but it comes with its cost. So there are certain limitations to consider it as a uh, uh, limitations for the liver biopsy. First, it is a invasive, and it samples around 1 in 50,000 of the whole liver. So it takes only a small, tiny piece of liver to represent the whole liver. And with the histological specimen, there is an intra and inter-operator variability. So one time the pathologist may report, oh, between the pathologist, the histology reporting might be varying. And answer, because of the invasive nature and the high risk of complication, it is unsuitable for the repeated assays. And there are complications, so that includes morbidity and the mortality. So around 0.6% of the patient who undergoes biopsy may bleed, or 0.1% may die. And there's a cost also high. So it cost around 1 lakh to 150,000 in a government sector or private sector. And because of the invasiveness, risk of complication, there is a increased patient reluctance as well. So because of this, we have to find a non-invasive method to determine the degree of fibrosis. So there are certain tests we should develop in the context of finding the fibrosis in the non-invasive way. There are advantages with the non-invasive test, such as these non-invasive tests are safe and they assess the level. So with the non-invasive test, we can identify, so we can rule in or rule out the fibrosis, and those are cost effective compared to the liver biopsy. So if you do the elastogram in a private sector, that also cost only 7,000, but liver biopsy it's around 150,000, and it is reproducible. And because it is cost effective and reproducible, you can use it as a tool for the disease monitoring. And sequential use of NIT may increase the number of patients identified with advanced fibrosis. So then we move into what is good non-invasive test. So good non-invasive test has both sensitive and specific in determining the presence or absence of fibrosis. So here, so you can see there is a low cutoff value and the upper cutoff value. So if you take upper cutoff value, so for example, I am taking as a taking the common one, the FIB4. So if you take the FIB4, the upper cutoff value is 2.67. So once the patient is having a value more than 2.67, you can rule in the advanced fibrosis. So that has a high specificity, high specificity ensuring that the patient are not wrongly diagnosed with the advanced fibrosis. Like, but the low cutoff value, that is around 1.3, maximize the sensitivity. So that means the advanced fibrosis are not wrongly excluded, right? So, and there is a indeterminate component. So that is 1.3 to 2.6. So in this context, we have to apply the second test. So second test, what we have. So first FIB4, then second test might be either fibroscan or ELF panel. So with that, you reduce the number of patients who fall in the indeterminate category. Right. So basically, the sequential use of NIT increases the sensitivity and specificity that reduces the number of patients in the indeterminate zone. So with the assessment of liver fibrosis, there are 5-point scale. So F1 is no fibrosis, F4 is cirrhosis. So there are F1 to F3. F1 is portal fibrosis without septa or mild septa. F2 few septa or moderate septa. F3 numerous septa without cirrhosis. So presence of cirrhosis categorized into F4 fibrosis. So for a practical reasons, we categorize the fibrosis into clinical significant fibrosis, that is more than F2 fibrosis, and advanced hepatic fibrosis, that is F3 or F4 fibrosis. So there are several types of non-invasive tests from the simple scores, serum markers, and imaging. Right. So we will go through one by one. So serum biomarkers. So serum biomarkers basically classified into direct, non-invasive, direct serum markers and the indirect, that is complex, patented biomarkers. So indirect biomarkers, we can use it in our normal clinical practice. So indirect biomarkers, that is derived from our routine liver biochemistry and the patient's data. For example, AST-ALT ratio, APRI, FIB4. You might have heard about this, and NAFLD fibrosis score. And the complex serum-based tests are patented, and those are ELF, enhanced liver fibrosis panel, fibro test, and fibrometer. And then image-based techniques. Image-based techniques, there are three image-based techniques. One is the transient elastogram, that is one we are using here. And other one is ARFI, that is acoustic radiation frequency impulse, and other one is the MR enterogram. So as you can see below the diagram, so you can see the cost and the how the cost and availability varies, and the availability from primary care setting to liver related centers. So the MRI is the best, although the MRI is the best method to assess the fibrosis, the cost and the availability is the limiting factor. So first, we will go through the simple serum-based test. So as I have mentioned before, it uses the information from the standard liver test and the patient data, and it is extensively validated across the spectrum of the chronic liver disease, and it is less accurate compared to the other patented complex serum test. So this is the one I have talked about. So as you can see, these are the common two scores we are using in our clinical practice, and one is the FIB4 score and other one is the NFS score. So FIB4 score, you see the basic parameters we are using here is the full blood count and the AST-ALT. So with three, the patient data is age. So with four variable, you are calculating the FIB4 score, and with the FIB4 score, if the FIB4 score is FIB4 is less than 1.3, so that means you can rule out the advanced fibrosis with the 95% negative predictive value. Whereas if the FIB4 score is more than 2.67, you can predicts the fibrosis with the 75% of the positive predictive value, right? So as I have discussed, so you can see the low cutoff value and upper cutoff value and indeterminate range. So next we move on to the complex serum markers. So these are the patented tests, and it incorporate the direct markers of liver fibrosis. Either it could be from markers of fibrogenesis or fibrinolysis. So common two or three markers are the procollagen 3 and hyaluronic acid and tissue metalloproteinase inhibitor like markers are used here in the patented test. And compared to the normal or indirect serum markers, so these are more accurate in predicting fibrosis and cirrhosis. So next we move on to the image-based technique. So what we have around a decade back is a conventional ultrasound scan to detect the cirrhosis and the advanced fibrosis and the cirrhosis. But now we have, so the problem with the conventional method of scans are, one is it detects the fibrosis in the later stages. But in the image-based techniques, with the image-based techniques, they uses the elastography techniques that uses the stiffness as a surrogate marker for fibrosis, and compared to the conventional imaging methods, that is more accurate. So what you have seen in the screen is the model of the fibroscan measure. So it measures the liver stiffness, which correlates with the fibrosis. That is basically using 50 hertz of shear wave to measure the stiffness. So the advantage is it measures greater volume compared to the liver biopsy. So liver, it measures only in 1 in 50,000, but here it's around 1 in 500. So 100 times better specimen we get through uh, fibroscan. But the limitations are, one is obesity. So we can't sometimes measure the uh, liver stiffness with the normal medium size probe. So we may need extra large probes if the patient is obese. And other than that, there are other confounding factors like local or systemic inflammation like hepatitis, cholestasis or congestion may give false liver stiffness. That means you can overdiagnose fibrosis if the patient has ongoing hepatitis, cholestasis or any liver congestion. So second image modality is the MR elastogram. So MR elastogram, it estimates the average degree of fibrosis throughout the liver. So it is far better than other two. So here that 1 in 50,000, 1 in 500, it gives you the picture almost the average throughout the liver. And it is more specific and sensitive compared to the other modalities. But the limitation here is cost, availability, and the level of expertise. So this is what I have talked about. So the accuracy is going increasing in the upward direction, where the MR elastography on top, while the accessibility and easy of use, it going down. So next thing is how we are going to use non-invasive test in the clinical practice. So, effective way of using NIT is, first we have to understand certain things. One is NIT are not sufficiently predict when used in an isolation. So if better to use sequential non-invasive test rather than going by isolation. And there's a testing algorithm based on primary care screening followed by GI or hepatology referral would best fit practice model for the management with the liver disease. So this is the primary care or non-GI hepatology care algorithm. So if a patient comes with the elevated transaminases, first what we have to do is the calculate a indirect or simple serum-based score. So that is the common one we are practicing here is the FIB4. So you calculate the FIB4, and if the FIB4 is less than 1.3, no need of hepatology or gastroenterology referral. So at that point, what you have to do is you have to monitor the FIB4 either 1 to 2 yearly or 2 to 3 yearly. So if the patient has diabetes or pre-diabetes or more than 2 risk factors, so assess the FIB4 1 to 2 yearly in regular clinics or diabetic clinic. If the patient doesn't have any risk factors for a metabolic syndrome or no diabetes or pre-diabetes, it is enough that you measure that you reassess the FIB4 in 2 to 3 year interval, right? So if the FIB4 is more than 1.3, and you have to decide whether you are going to refer to the tertiary care center for a liver or hepatology side, or you are going to further progress. So the secondary risk assessment, you can either do it in a primary care or you can refer to the hepatology center. So secondary assessment. So usually what we do is what we do here in Sri Lanka is transient elastography. So that is fibro scan. So with the fibro scan, we can categorize. So if the liver stiffness measurement is less than 8, so that is rule out fibrosis. So in that category, you can again take it to your primary care management and follow up as this, reassess with the FIB4 model, right? And if the patients have if the FIB4 is more than 2.67 or persistent ALT, and if the secondary assessment shows intermediate or high risk category, you refer the patient to the hepatology or GI care. Meanwhile, all the patients should be addressed on lifestyle modification and complete abstinence of alcohol. So that is very important. Even a unit of alcohol in the context of fatty liver is harmful. So complete abstinence of alcohol and cardiometabolic risk factor. Also be aware that there are different cutoffs for age more than 65. So as age is a component in the age is a component in the FIB4 score, more than 65 itself may have a high value. So be aware there is different cutoff for age more than 65, and the limited value if the patient is less than 35 years of age. Right. So this is what we do in our hepatology setup. So once we receive the patient with the intermediate or high risk, so the main aim is to identify the high risk or at risk patient. So at that level, we evaluate the patient for primary and secondary assessment and find whether the patient is having high risk or intermediate or high risk. So it depends on that, we have to decide whether this patient is having advanced cirrhosis. So in the presence of advanced cirrhosis, we have to start the management based on the guidelines for the management of cirrhosis. But in certain indications, there is a place for biopsy. One is the intermediate non-invasive test. So after second non-invasive test, if the patient fall into a category indeterminate slot, you have to go for the biopsy. And other one is the diagnostic uncertainty. Sometimes steatosis is a presentation of Wilson disease or autoimmune hepatitis. So you screen for the secondary markers, and if anything positive, and you are not sure that this diagnosis could be due to Wilson disease or autoimmune hepatitis, you have to go for the biopsy to clear the diagnosis. And if the AST ALT is persistently high, so with the biopsy we have to stage the histology, stage the fibrosis. So 0 to 1, 2 to 3, and 4. So it depends on that, the reassessment frequencies varied. Right. So that's about the assessment of the liver fibrosis. Now we move on to the assessment of the clinically significant portal hypertension. So before going into that, the cirrhosis basically, as you all know, the basically categorized into compensated cirrhosis and decompensated cirrhosis, depends on the presence or absence of clinically evident decompensation event. So if the patient has a compensation cirrhosis, the survival is good. Survival is good. So the median survival of the patient with a compensated cirrhosis is around 12 years, whereas the decompensated cirrhosis survival is around 2 years. So again, with the compensated advanced chronic liver disease, so we divide into two. Depends on the degree of portal hypertension. One is mild portal hypertension. Other one is the clinically significant portal hypertension. So clinically significant portal hypertension, that is based on earlier. That is completely based on HVPG, that is hepatic vein pressure gradient. So the hepatic vein pressure gradient is around 6 to 9, that is mild portal hypertension, and if that is beyond 10, that is called clinically significant portal hypertension. And the mortality also differs. It is increased in patient with clinically significant portal hypertension. So these are the techniques that are used to identify clinically significant portal hypertension. Those are in the green are the invasive methods. So those are biopsy and HPG that I am not going to discuss here. So there are other things, other non-invasive things. One is the plasma markers, and other one is the liver stiffness measurement and the screening stiffness measurement. So plasma markers, these are not available in our country yet. So there are 1 milligram factor antigen, AST to platelet ratio index, and ELF score. And I'm not going to discuss those things in detail. And the liver stiffness measurement I will discuss in other slide. So stiffness measurement also can be used as a marker of portal hypertension. So if it is more than 40 to 45, you can take it as a marker of clinically significant portal hypertension. So as you see, these are the values we get in the assessment of liver stiffness measurement. So first is the diagnosis of compensated advanced chronic liver disease. So that is, if the liver stiffness measurement is more than 15, that is highly suggestive of compensated advanced liver disease, right? So if it is less than 10, that is no chronic advanced liver disease, and there is an indeterminate zone here, that is 10 to 15, that is possible for chronic advanced liver disease. And with the liver stiffness, if you combine the platelet count, you get an idea whether the patient is having clinically significant portal hypertension. So if the liver stiffness is more than 25, you don't need a platelet count. That is suggestive of clinically significant portal hypertension. And if the liver stiffness is 20 to 25 and the platelet is less than 150, or if the liver stiffness is 15 to 20 with the platelet count is less than 110, it's a diagnosis of clinically significant portal hypertension. So this is, I'm not sure whether it is clear or not. So here, if you see the third column, the endoscopy. So I will show the next. I will show you the next slide. Anyway, so this endoscopy also we are deciding depending on the non-invasive test. So if the patient is having liver stiffness measurement 20 less than 20 kilopascal or platelet more than 150, the endoscopy is no more indicated. So you can straightly start away the beta blockers. If it is more than that, you can straightly start away the beta blockers. Okay. So here, so this is what the new things. So in the old guidelines, what we have seen is the compensated cirrhosis. So any degree of cirrhosis, you do the upper GI to see the variceal status. So it depends on the presence of varices or not. You decide what is the kind of management you are going into. So that could be endoscopy yearly or an endoscopic screening or non-selective beta blockers. So variceal band ligation. But the new paradigm says that in a patient with a compensated cirrhosis, you can decide the treatment with the liver stiffness and the platelet count. So once you diagnose the clinically significant portal hypertension with liver stiffness and the platelet, you can decide whether to start non-selective beta blocker. So usually what we start is carvedilol 12.5 milligram daily, right? So if the patient is not diagnostic of clinically significant portal hypertension, that means if the liver stiffness is less than 20 or platelet more than 50,000, we don't need anything like endoscopy or beta blockers. But what we have to do is we have to monitor the liver stiffness and platelet yearly and decide whether he falls into the clinically significant portal hypertension. So that is the end of my talk. These are the take home messages. Given the significant prevalence of liver disease and the associated hazards and discomfort associated with the liver biopsy, there is a crucial need for the precise and dependable non-invasive testing methods. The evaluation of fibrosis is essential for recognizing the progression of the disease, devising treatment strategies, averting complications, and obtaining prognostic insights. Non-invasive testing comprises serum imaging, either used individually or in conjunction. Proposed algorithm for primary screening NIT prior to referral, followed by more specific NIT testing in hepatology clinic. Liver stiffness, along with the splenic stiffness by transient elastography, is useful establishing diagnosis of clinically significant portal hypertension. In a compensated cirrhotic patients, non-invasive test has replaced the need of initial screening with upper GI and initiation of non-selective beta blockers.
Thank you very much, Dr. Nimalan, for that comprehensive talk on non-invasive strategies we can use to diagnose liver fibrosis. Are there any questions?
Fibroscan is available in Ragaman, Kandy, and now there are few hospitals getting fibroscans.
The concept of decompensation, is it possible at all levels of liver sickness, or is it possible throughout the spectrum, or is it at a certain endpoint? Agents and endpoints?
So, decompensation in the patient with the decompensation.
You talked about this new concept of decompensation.
Yeah.
So is that possible at all levels of liver sickness, that is all levels of advanced CACT, or is it
Yes,
something that is limited to certain
decompensation we defines is the returning from the decompensated to compensated. So the stiffness is, if you take advanced fibrosis or compensated cirrhosis, that patient stiffness is already more than 15, 20, 25, more than 75. So the stiffness doesn't relate with the recompensation. So even in the patient with a decompensated cirrhosis, once the insult is stopped, so if the patient is completely abstinent from the alcohol, after some times, these features of decompensation might disappear. So the edema disappear, sepsis disappear, and uh, patient may return to the compensated state without any edema or varices.
hypertension also come down?
Yes. Yes.
Okay, thank you.